We move on with the next presentation, and the next one is about dilated cardiomyopathy and myocarditis. Okay, so dilated cardiomyopathy is a disease of the cardiac muscle, and the typical phenotype is a dilated left ventricle associated with systolic and or diastolic dysfunction, most commonly the systolic dysfunction. The right ventricular dysfunction may also be present even at earlier stages of the disease, and it is important to notice that left ventricular dilation may very frequently anticipate left ventricular dysfunction. So you have a large left ventricle that after years may develop left ventricular dysfunction. What are the most common causes of dilated cardiomyopathy? Well, the causes are extremely variable. Can go from genetic disease, so this can be an inherited cardiac disorder, so present when the child is born, but even later in life, or can be due to the activity of toxic agents such as drugs or exposure to some other agents, or maybe due to a viral infection, so as a consequence of myocarditis, or maybe the consequence of some immune disorders in the individual. So all these causes, all these etiological causes may be responsible for dilated cardiomyopathy. And it is important to recognize the dilated cardiomyopathy because it is reported among the causes of sudden cardiac death in young competitive athletes. And in detail, dilated cardiomyopathy has been reported as 4% of the causes of sudden death, and myocarditis, again, 4% among the causes of sudden cardiac death in young athletes. And how can the sudden cardiac death occur in this individual? Of course, to have a sudden cardiac death, we need a pathological substrate that you can see here. You can see areas of disarray or scar within the left ventricle that represent the substrate. And over this substrate, some stimuli, such as increased catecholamine levels or acidosis during sport activity or dehydration, can be responsible for the occurrence of malignant ventricular arrhythmias, and this may lead to the sudden cardiac death. So how can we make a diagnosis of dilated cardiomyopathy in athletes? Because you know that in athletes it can be difficult because some athletes, especially those involved in endurance sport discipline, may show with large left ventricle. So there is an overlap between the athlete's heart and dilated cardiomyopathy. So what is our diagnostic approach for this condition? So the first point, of course, is the clinical and family history. We know that it can be an inherited cardiac disorder, so we have to deep investigate the family to understand if there is any sudden cardiac death in the family or other cardiomyopathy in the family, or exposure to any kind of drug or substance that can lead to this condition. And then we have, of course, the ECG and cardiac imaging. With regard to the ECG, this is not really a good news because the electrocardiographic findings in dilated cardiomyopathy are not so specific, such as in hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy. However, you can find T-wave inversion in almost 25 to 45% of individuals. You can identify Q waves in 10 to 25% of the affected subjects, and also left bundle branch block can be identified in almost 1/4 of patients with dilated cardiomyopathy. Some electrocardiographic findings that have been proposed are the so-called Goldberger triad, and it's a combination of 3 different findings. So one is LVH, so LV hypertrophy in the anterior precordial leads associated with low voltages on limb leads, and the third one is poor precordial R-wave progression. And here is an ECG of a subject with dilated cardiomyopathy, and you can see that there are negative T waves diffusely present, but you can see that there is poor R wave progression in the anterior precordial leads. So these are some findings that you can identify on ECG. And then I said it's important to do cardiac imaging because, of course, it's a phenotype, and the phenotype can be identified with imaging, so with echocardiography and cardiac magnetic resonance. But as I told you, there is some overlap in terms of left ventricular remodeling in athletes with the pathologic findings in a subject with dilated cardiomyopathy. So when we perform an echocardiographic examination and we find a large left ventricle, what we have to do is to interpret these findings in the context of the gender of the individual, the body surface area, and also, of course, the type of sport that the athlete is doing. In terms of left ventricular cavity dimension, as you can see here, this was a study published by Pelliccia in 1999 that reported that male athletes have larger left ventricle compared to female athletes. So large left ventricle in female athletes should raise some suspicion. And up to 14% of individuals may show with a left ventricular cavity size more than 60 millimeters, so a significant change. But these are only male athletes, while on the other side, only very rarely female athletes have values above this cutoff of 60 millimeters. So, however, what is important, as I told you, is that you have to interpret this finding of a large left ventricle in terms of the body size of the athlete. Indeed, several studies that were done, both with M-mode echocardiography, two-dimensional echocardiography, but also with three-dimensional echocardiography, reported that around 50% of the variability in left ventricular size can be explained by the body surface area. So what I suggest you to do is that when you are reading an echo, you have to identify the values corrected by the body surface area. And specifically, an enlarged left ventricle would be defined by an increase by values more than 40 millimeters per square meter in female athletes and more than 35 millimeters per square meter in male athletes. And in terms of volume, the cutoff are 93 for female athletes and 108 for male athletes. So remember these values because indexing the left ventricular size is important to the interpretation. The other point is that, of course, the type of sport would impact the size of the left ventricle. So an athlete, a bowling athlete or an archery athlete will not have the same left ventricle as a rower or as a cyclist. And as you can see, this is a study that we did with three-dimensional echocardiography, and you see that with increasing hemodynamic overload, going from skill to strength, combined or endurance athletes, there is an increase in end diastolic volume of the athletes. But what I would like to show you is that the increase in left ventricular cavity size is always associated with an increase in left ventricular mass. So the increase in left ventricular size is also associated with the increase in left ventricular wall thickness, and you will always have a balanced ratio between cavity and wall thickness. In terms of gender, the gender doesn't seem to impact left ventricular cavity size. And there are two studies that have been published, one from Fernando from our institution and the other one from the group of Sanjay Sharma, that reported that left ventricular cavity size is not different among black or white athletes. So the ethnicity doesn't seem to impact left ventricular size. The other point is left ventricular function. So how can we define a normal left ventricular function in athletes? Because there are some reports, there are some individuals, some subjects that say that even a mild depression in left ventricular function may be normal. Well, this is absolutely not true because we analyzed this in our athletes, and over more than 1,000 athletes, we didn't find anyone with left ventricular systolic dysfunction. We didn't find anyone with even mild left ventricular systolic dysfunction. And if you look at this graph here, this bar chart, you can see that a reduction, that the 5th percentile of ejection fraction in our study population was 55%. And only few athletes had values below this cutoff, but they had values around 53 or 54, but no one had values below 50%. So when you find an ejection fraction of 47 or 48, this should be regarded as a pathologic ejection fraction, a pathologic left ventricular function. So now I would like, of course, there are some exceptions, and I would like to show an exception of this. This is a case of an 18-year-old male, a soccer player. He was completely asymptomatic, had a negative family history. This is the ECG, which was quite normal. And you can see that there is just a poor R-wave progression in the precordial leads, high voltages. And here we have the echo. And this is quite a large left ventricle, you can see here. And the ejection fraction was in the lower limit under the resting condition. We judged that it was 50%. So in cases where the ejection fraction is borderline, what we do is to ask the athlete to perform an exercise, and this is what you can find. When you do an exercise, you see that the ejection fraction increases significantly from 50% to more than 70%. And you can see that the function is normal, so this left ventricle is absolutely normal. You can see this is the baseline, and this is during exercise testing. So when you have a borderline ejection fraction, the exercise testing is an important tool. This is another case. This is a 47-year-old female, a Paralympic archery athlete affected by multiple sclerosis. She had frequent PVCs with left bundle branch block pattern, more than 46,000 over 24 hours, but also had 97 couplets and 1 non-sustained ventricular tachycardia. This is the baseline ECG, and you can see that there is poor R-wave progression in the precordial leads with high voltages. And you can see that this is the baseline examination. The ejection fraction was 46%, so an abnormal ejection fraction. And during exercise testing, it increased a little bit, but it was considered not sufficient to identify a normal response. So because of the low ejection fraction, the large left ventricular cavity, and the arrhythmias in this athlete, this was considered an abnormal finding, and the athlete was eventually disqualified from training and competition. So stress echo and also the information that you gain from the exercise testing and from the ECG alter monitoring can be helpful for identification of patients with dilated cardiomyopathy. Of course, cardiac magnetic resonance may be of help because it has a very high spatial resolution and can provide also tissue characterization. Indeed, cardiac magnetic resonance is particularly important to identify areas of fibrosis within the myocardial wall. And patients with dilated cardiomyopathy may have different patterns of fibrosis that can be patchy or can be diffuse or can be subepicardial or subendocardial, so different areas of fibrosis within the left ventricle. But the important message here is that the presence of fibrosis is a negative prognostic marker in terms of survival of individuals with dilated cardiomyopathy without ischemic heart disease. And this is a study that was published in JAMA in 2013, where 472 dilated cardiomyopathy patients were studied and followed up over time. They did not have coronary artery disease, and you can see that those that had fibrosis identified with cardiac magnetic resonance had a poor prognosis. So what is a proposed management protocol for the athletes with large left ventricle? So when we have an athlete that is identified with a large left ventricle on echocardiographic examination, so with a diameter more than 60 millimeters, but the ejection fraction under baseline evaluation is normal, so this is to be considered a physiological adaptation. But on the other side, if the left ventricular diameter is more than 60 millimeters and the ejection fraction is in the lower range or even a little bit reduced, what we suggest to do is an exercise echocardiography, so an exercise testing with imaging. And if the function of the left ventricle is good on exercise testing, so this is a normal finding and it could be considered a physiological adaptation. But on the other side, if you find an abnormal function on exercise echo, what we suggest to do is to do a CMR with gadolinium, and after that, after considering the overall clinical picture, you can make the diagnosis of dilated cardiomyopathy. So in case you reach a diagnosis of dilated cardiomyopathy, what is the suggested behavior in terms of sports eligibility? So we have some differences in terms of American and European guidelines, because the American guidelines consider only individuals with a symptomatic disease, and they say that if the subjects are symptomatic, no competitive sports, but if they are asymptomatic, they say that sport activity can be suggested after a comprehensive evaluation of the athlete. Because the reason for this is that there is no evidence, this is what they say, there is no evidence that sudden cardiac death will happen in individuals that are asymptomatic. On the other side, in Europe, we are a little bit restrictive, and usually when a diagnosis of dilated cardiomyopathy is reached, we suggest no competitive sports. But there are some individuals that can be considered at low risk, and these subjects are those that have no symptoms, that have an ejection fraction that is just mildly depressed, more than 40%, that have normal blood pressure response to exercise and have no ventricular arrhythmias. So in these cases, we consider the individuals with a low risk profile, and we can allow them to continue with low static and low moderate dynamic exercise, so just mild competitive activities. So now we move on. Should we stop here or we move on to myocarditis? I think it's better to move on with myocarditis. So what is myocarditis? Myocarditis is an inflammatory disease of the myocardium, that cause usually loss of myocytes and necrosis of myocyte cells, and it is usually secondary to a viral etiology. The diagnosis, the serious diagnosis, can be done with histology, with the so-called Dallas criteria, that is characterized by inflammatory infiltrates, myocyte degeneration, and or necrosis within the left ventricle. What is the mechanism of myocarditis? So what happens during myocarditis is that there are some agents that can cause the disease, such as microbial infection, most frequently viruses, or even non-infectious damage, such as some chemical substances. These agents may cause a direct damage of the left ventricular or the myocardium, and this can cause an immune reaction. In the majority of individuals, the immune reaction will cause a healed myocarditis. So after several days or weeks of the disease, there is a healed myocarditis. But in some other individuals, and most frequently when there is a specific genetic background or a genetic predisposition, the inflammation can be a little bit different. So the infection can become chronic. There can be some exposure of myocyte antigens to the immune system, and this can cause activation of cross or autoreactive T cells and induction of autoantibodies and cause autoimmunity. And this can cause a chronic infection, they call the chronic myocarditis, and the evolution can be in dilated cardiomyopathy. So why is myocarditis important in athletes? It is important because the exercise activity may be very dangerous in these individuals for different aspects. The first one is that an intense exercise may cause upper way respiratory infection, may have a depressant effect on T lymphocytes. It has been demonstrated that can cause an increased replication rates of the viruses, and most importantly, can cause an increased sympathetic tone that can have adverse effect on the myocardium and can cause arrhythmias and sudden cardiac death. And what is important is that the sudden cardiac death during myocarditis can occur at any stage of the disease. It can occur during the early phases, during the active phases, but also during the healing phase of myocarditis. How can we make a diagnosis of myocarditis? There are several criteria. In terms of clinical presentation, patients may have chest pain, dyspnea, or fatigue. They can have symptoms such as palpitation or syncope, or in the worst cases, aborted sudden cardiac death. And in terms of instrumental findings, you can identify some ECG abnormalities such as AV block, left bundle branch block, or ST segment or T wave abnormalities. On lab tests, you can identify elevated markers of cardiac damage such as troponin, or of course inflammation markers. And on echocardiography, you can find different markers of dysfunction of the left ventricle, or edema or pericardial effusion. And on CMR, you can have some markers of edema or fibrosis of the left ventricle. And we will see this in next slides. So on echocardiography, you can identify different patterns. This is an example with a dilated left ventricle and thin walls. And this is another example, and you see that there are thick walls because of edema and a mild dysfunction and also pericardial effusion. So the imaging findings can be extremely variable in individuals. Okay. In terms of cardiac magnetic resonance, there are different patterns that can be identified. So I think that maybe yesterday Viviana Massini told you already about this, but there are some specific findings that can suggest that there is edema within the left ventricle or fibrosis within the left ventricle. So CMR can be quite specific for a diagnosis of active phase of myocarditis or healing myocarditis. I would like now to show a couple of quick examples of cases of myocarditis. This is a 31-year-old young lady that I could see at the emergency department. She had fever and weakness since several days, and she complained about palpitation, and she had 2 or 3 episodes of unexplained syncope. She came at the emergency department at hospital, and you can see that there are some abnormalities on the ECG, some low voltages in the limb leads. There is some ST depression in inferior leads, and also here in V5 and V6 with mild abnormalities of the T wave. So at that time, I decided to do an echocardiogram, and you can see that the left ventricle was mildly dilated and the function was a little bit reduced. You can see this from the parasternal short long axis view. But even, okay, this doesn't work well. However, the ejection fraction was mildly reduced, was 45 to 50%. And while I was doing echo, suddenly she had some palpitation, and this is what happened to her. So she was with the monitor, and she had a ventricular arrhythmia, and she was at the emergency department, so we had a defibrillator, and she was resuscitated, and she had her life saved. But if this arrhythmia happened outside, maybe she could have died because of this myocarditis. So this is to demonstrate how harmful myocarditis can be and how unpredictable sudden cardiac death may be when there is a myocarditis. This is a second case. This is a 20-year-old male, Olympic swimmer, with a negative family and personal history and normal physical examination. This is the baseline ECG that shows that there are some ventricular arrhythmias. In particular, here there is a left bundle branch block PVC. And he did an echocardiogram. The left ventricle was a little bit dilated, 62 millimeter, but it was not considered pathological. The septum was 12, the posterior wall was 11, and the ejection fraction was 61%. On exercise testing, he had several arrhythmias. You can see that he had a couplet with right bundle branch block morphology, and here another couplet with one is right bundle branch block morphology, and the other one is left bundle branch block morphology. So polymorphic ventricular arrhythmias. He did a 24-hour Holter monitoring, and he had more than 700 polymorphic ventricular ectopic beats, 24 couplets, and 5 non-sustained ventricular tachycardia. Of maximum 3 beats. And we did a CMR, and the CMR demonstrated an area of fibrosis in the epicardial region of the lateral wall of the left ventricle. And this finding was considered consistent with a healed myocarditis, a recent and healed myocarditis. So the presence of areas of fibrosis on CMR, the presence of late gadolinium enhancement, has a bad prognostic significance. And this has been demonstrated by this study that was published in JACC in 2012. 203 patients with a biopsy-proven myocarditis with an age of 40 to 54 years of age underwent a CMR, and they were followed up for 4.7 years. And those that had late gadolinium enhancement identified on baseline examination had a poor prognosis, as you can see here from the red line. So, again, finding of a fibrosis after a myocarditic process has a bad prognostic significance in patients with myocarditis. So what are the recommendations in terms of exercise activity and sports eligibility in individuals with myocarditis? So the recommendations are quite similar from the American guidelines and European guidelines. During an active phase of a myocarditis, no competitive sports. So, and this recommendation should go on for 3 to 6 months. And when to resume training individuals with a previous myocarditis. You can resume training if there is a normal left ventricular function, if the blood test normalized, so if you don't have inflammation markers, and if you don't find arrhythmias on 24 hours ECG monitoring, and you don't have arrhythmias during an exercise testing. But a problem that I will discuss maybe with my friend Alessandro is what about an athlete that had a healed myocarditis, but you do a CMR and still there is some fibrosis, still there is some late gadolinium enhancement. So this is still an unresolved problem for the sports cardiologist. And what we usually recommend, what we say is that if there are small areas of late gadolinium enhancement but not associated with arrhythmias, you can consider maybe sport activity. But if you have bigger areas of late gadolinium enhancement and you also have arrhythmias, you should stop the athlete. And there is a study that Alessandro did recently and published in Circulation about areas of scar in the left ventricle. And in this study, there were 35 athletes with ventricular arrhythmias and positive late gadolinium enhancement that could be even consistent with the previous myocarditis. And 22% of those athletes that had the association of a positive late gadolinium enhancement with a stria pattern, so not patchy areas of late gadolinium, with a stria pattern, and this was associated with ventricular arrhythmias, had a bad prognosis. So when you still find some areas of positive late gadolinium enhancement with a stria pattern and you have arrhythmias, you have to definitely stop the athlete after a myocarditis. So thank you very much for your attention.